right, Kim.
We're going to go ahead and get started since now it's 12. So thank you everyone for joining us today. Just going to do a quick introduction. So my name is Kimberly Mankus. I'm a health educator at the Blum Center here at MGH.
And my name is Mariam Daib. I'm also a health educator here at the Blum Center.
And my name is Dr. Brian Scacco, and I'm delighted to be here today as your speaker.
Lovely. So before we get started, I'm just going to go over a few things. Please note that this session is being recorded for educational purposes. If you're interested in viewing this recording, it will be made available on the Blum Center website as well as our Mass General YouTube channel. Everyone is in listen-only mode, so everyone has been muted to eliminate background noise so that we can hear our speakers. If you have a question, please use the chat feature at the bottom of the screen. Only the Blum Center staff, the co-host, and the guest speaker will see your questions. We will have time at the end for the session for questions, so please don't share any medical information in the chat as well. If you have a medical question, please ask your doctor. And now I'm going to hand it off to Brian to begin his presentation for us today.
Thank you, Miriam, and thank you, Kimberly, for inviting me here today. It is such a delight to be here, and thank you for everyone tuning in to learn a little bit about Down syndrome. I am the director of the Down Syndrome Program at Massachusetts General Hospital, and I regret that my co-presenter, Chloe Cottrell, who's our social worker, is not able to join us today for a family emergency, but I am proud to be able to present slides, and I want to give her credit for also helping to prepare these slides for today. At Mass General Hospital, we have a comprehensive multidisciplinary clinic for and with people with Down syndrome, and I hope today, by the end of the hour, you will learn a little bit more, not only about Down syndrome, but about the clinical care that we're providing, not only to patients who come to MGH, but also to patients from around the world with a new virtual clinic that we are launching. So I look forward to presenting to you my information, and I have reserved some time at the end to take your questions. I know many of you have a loved one with Down syndrome. You might have a family or friend with Down syndrome. And by the end of this talk, I hope you will be able to learn a little bit more about their potentials. Great. And why we bring the first slide up. Great. We'll go to the next slide, please. So just to make sure we're all on the same page, Down syndrome is one of the most common chromosomal conditions in humans. And I want to take us all back to a course in genetics again. I'm a medical geneticist by training here at Massachusetts General Hospital. And when it comes to genes, those are the packages that have all of chromosomes, have the packages of all of our genes in our body. And the typical person has 23 pairs of genes, giving a total of 46 chromosomes. But in someone with Down syndrome, they have an extra chromosome, or chromosome number 21. And here in this karyotype, which is a picture of our chromosomes underneath the microscope, you could see the first pair is number 1. It's the tallest. The second pair is number 2. It's a little bit smaller than number 3. In each pair of chromosomes, we get one chromosome from our biological mother and one chromosome from our biological father, one from the sperm, one from the egg. So you should have a total of 23 times 2 or 46 chromosomes in the typically developing person. But in someone with Down syndrome, when you look down there to where the red arrow is, you could see rather than having 2 copies of chromosome 21, people with Down syndrome have 3 copies of chromosome 21. And this is why people with Down syndrome is also called trisomy 21, or 3 copies of chromosome 21. This means people with Down syndrome have 46 plus 1 or 47 chromosomes. Next click will show that there are 2 other types of Down syndrome. One is called translocation Down syndrome. And if we could have the next click, please. Translocation Down syndrome is where that extra copy of chromosome 21 is attached to another chromosome. And then here we have a picture of what's known as mosaic Down syndrome, where some cells have an extra copy of chromosome 21 and some cells do not. There are more than 210,000 families who have a loved one with Down syndrome in the United States and more than 5,000 children born each year. Next slide. One of those people who has Down syndrome is my own sister, Kristen. Kristen is now 40 years old with Down syndrome, and she certainly is the passion and the motivation for me doing what I love to do here at MGH. Next click. How could you tell that someone has Down syndrome? So there are some clues, and looking here, we could see that people with Down syndrome often have eyes that are shaped a little bit like almonds, and so they're called almond-shaped eyes. And sometimes their eyes could be upward slanting, but here if you zoom in and if you look at the iris or the colored part of the eyes, you know that there are little dots around the eyes of this person. They look like little twinkles around the eye. Those are called brush field spots, and they don't have any bearing on one's eyesight, but this is one of the clinical ways that we make a diagnosis of Down syndrome when we're seeing babies for the first time. Next slide. Another way we could tell that someone has Down syndrome is sometimes when you look at your hands, and you could look at your hands right now, you could see that there are lots of different creases we have on our hands. Someone with Down syndrome, you could see that they often have a single palmar crease, which means that there's one crease that makes it from one side of their hand all the way to the other. And in the picture to the right, you could see that people with Down syndrome oftentimes have a wider space between their first and second toes. Now, none of these characteristics have any medical bearing, but these are the ways that when a baby is born and we're called to do an examination, we could start to look to see whether or not that baby might have characteristics of Down syndrome. And if they do, then we will order one of those genetic karyotypes that I showed you to look at their chromosomes and zero in to see whether or not we have confirmed that diagnosis. Next slide. Like I mentioned, there are more than 213,000 Americans with Down syndrome, and now people with Down syndrome are living longer than they've ever lived before, thanks to advances in medicine. The average age of someone with Down syndrome is now approaching 60 years of age. And this is some research that my colleagues and I have been doing, stitching together some of the registries and population databases from around the country. And you could see here that the number of 30-year-olds and 40-year-olds and 50-year-olds has been expanding in recent years. And that is, again, because we're able to keep them healthier longer. And as a result, we're having more babies with Down syndrome live to longer years. Next slide. Many of you know that there are prenatal tests available to detect Down syndrome in utero. My colleagues and I have also been tracking the number of fetuses with Down syndrome that are conceived. So you could see here the total length of the bar is the number of fetuses with Down syndrome from 1974 until the most recent data we have in 2014. The length of this bar is the total number of fetuses at 10-week gestation. And the reason why we have more fetuses with Down syndrome being conceived is we know that many women are waiting until they're older to have children in recent years rather than in yesteryear. And we know that the older a woman is, the increases chances she has of having a baby with Down syndrome. The light blue bars indicate the number of natural miscarriages that occur. The dark blue bars are the number of babies with Down syndrome that have been born in most recent years, around 5,200. And the orange bars indicate the number of elective terminations or abortions for Down syndrome. In most recent years, those are 3,500. Next slide. I want to talk a little bit about words. As many of you know, words matter no matter what diagnosis we're talking about. And when it comes to Down syndrome, words matter too. Just to say that the correct diagnosis is Down syndrome with a capital D and a lowercase s. There is no apostrophe s because Dr. John Langdon Down, who originally described Down syndrome in the UK, he himself did not have Down syndrome. Whereas other conditions like Lou Gehrig's disease, where Lou Gehrig himself didn't have it, gets the apostrophe s. So Down syndrome is named after the doctor from the United Kingdom who originally described what he saw as many people with similar characteristics. But we also know that words can create barriers. One word that is particularly stinging in our community and among those who have intellectual disabilities is the word retarded. We no longer use this R word, and it's something that we strongly condemn here at Massachusetts General Hospital and something that is not found in our vocabulary. And I would encourage you also to try to stamp out that word from others that you hear, because people with intellectual disabilities have said that that word, which was once a medical diagnosis, has now been used in slander. And we know that there is lots of potential for people with Down syndrome and intellectual disabilities, and we don't want them labeled inappropriately with those words. Next slide. We also, in our MGH Down Syndrome program, proudly use what's known as people first language. This is about putting the person first, not their disability. So instead of saying, oh, we saw a disabled patient or a disabled person, we instead say we saw a person with a disability. Rather than saying, oh, a Down syndrome child or that cute Down syndrome girl, we say we saw a child with Down syndrome. Because they're not certain segments of humans. They're not, oh, those are the Down syndrome kids or those are the autistic kids. No, they're first and foremost people like the rest of us. They are people with Down syndrome, patients with Down syndrome, patients with autism, patients with cerebral palsy, patients with cancer. We're proud at MGH to be able to use the language that our patients have taught us. We also like to encourage everyone to use emotionally neutral expressions. So rather than saying someone is afflicted with or suffers from, which is a value statement that might not be true, and certainly they might not feel is true, we simply like to say a person with cerebral palsy or a person who has Down syndrome. Next slide. We also like to emphasize the abilities, not the limitations in our vocabulary. So rather than saying someone is wheelchair bound, we simply like to say someone who uses a wheelchair. And rather than saying someone is in special ed, we'd like to say someone who receives special education services. And really to emphasize that they are using services and not defined or limited by those. And I would encourage everyone to continue to use the language that comes from the communities that we serve. Again, cognitive disability or intellectual disability is now preferred over mentally retarded. And when we're talking about people who are don't have disabilities, we like to use the word typical or neurotypically developing rather than normal, because using normal implies that anyone who's not normal is abnormal. And as people like my sister would say, she is anything but abnormal. Next slide. I want to give a little historical and societal context. Before the 1980s, the overwhelming majority of people with Down syndrome in our country were placed in institutions. But because of neglect, abuse, and lack of access to education and medical care, people with Down syndrome oftentimes would die early in these institutions. I'm proud that our society began to shift these understandings in the 1970s and 1980s with our fundamental focus on human and civil rights. And because of that, with the next click, you will see that people with Down syndrome are now living longer than they've ever lived before. Next click. You could see in 1980, the lifespan was 25 years, and in 2010, it's 60 years. And that's not because the genetics has changed. It's because we have. By giving the medical care that people with Down syndrome deserve, by supporting them, we are allowing them to live to their best potential. And I like to say the best is yet to come, because there are still many societal barriers that are getting in the way of people with Down syndrome and those with intellectual disabilities of living their full lives. Next click. I want to tell you a little bit about the Down syndrome program we have here at Massachusetts General Hospital. Next click. It was founded in 2012 and we expanded it in 2012. Founded in 2006 and we expanded in 2012. And we see patients with Down syndrome of all ages. There are 4 physicians listed here, myself being one of them, who see patients in our Down syndrome program. And when they come, it's a multidisciplinary experience. We don't provide primary care. Everyone has their own primary care provider, but we provide the Down syndrome tune-up. They come to see us and we make sure that nothing gets in the way, because by us seeing over 600 patients with Down syndrome every year, we know how to pick up on the small nuances so we can work with the patients, work with their caregivers, work with primary care physicians to be able to maximize their health and their wellness. Next click. When someone comes to our clinic, I did promise you it's multidisciplinary. Not only are they seen by the physician, they're seen by one of our social workers, Chloe or Jessica. They're also seen by one of our nutritionists, Dominica and Trudy. And they're seen by Ben Majeski, who is someone with Down syndrome described as a self-advocate who sees our patients and delivers his story and his recommendations on how they can live their best life. And also, this wouldn't be possible without an extraordinary cast and crew behind the scenes and in front of the scenes who are coordinating the day to make sure it runs smoothly. And I would like to thank all of our patient service coordinators and our administrative assistants. Next click. Our Down syndrome program is divided into 5 clinics. We have a prenatal clinic, and this is for those families who have received a prenatal diagnosis of Down syndrome and want to learn more about the condition before oftentimes they make a pregnancy decision. They're seen by one of us physicians, the program manager, and if they want to meet Ben, they're able to meet Ben. We meet them where they are, we answer their questions, and we make sure that they have the most up-to-date, accurate understanding of Down syndrome so that they can make a pregnancy decision for them. Next slide. In the infant and toddler clinic, we're seeing patients with Down syndrome every 6 months between the ages of 0 and 5. This is an all-day adventure when they come to MGH, and rather than making 9 or 10 different visits to the hospital, we carefully coordinate everything on one day because we get it. Parents have a lot on their plate, and rather than taking 9 or 10 days off of work, now they just have one day off of work where they could see all of the people listed here in one day. They will see a hearing doctor, an eye doctor, a physical therapist, an occupational therapist, a speech therapist, a dentist, a feeding therapist, and all the other people I've listed here. They rotate from room to room, and during the pandemic, from virtual room to virtual room in order to get the care that they deserve. On next click, you will see that then we have the child clinic. In the child clinic, we're now seeing people on an annual basis. And here we start to prune the number of people they rotate through as they start to reach a nice cruising altitude in terms of their healthcare. We're able to offer our audiologists listed here through our partnership at Mass Eye and Ear. And we also have great collaborations with psychologists, neuropsychologists, psychiatrists, and educational advocates, because we know so many of the questions that we're asked are not just about medicine, but are about school and about learning and about co-occurring mental health conditions. On the next click, we then have the adolescent and young adult clinic. This is where we're helping teens and young adults with Down syndrome march their way through puberty, better understand their bodies, better understand their emotions, and better understand social boundaries. We also know that there are some co-occurring mental health conditions that can occur during these ages, and we want to make sure that they're diagnosed accurately and that they're evaluated correctly, and that we're not making sure that they don't get in the way of good care. Next slide. We also have our adult clinic. Our adult clinic is for those individuals ages 22 and older, all the way up to 60s and 70s. And here is where we have our adult providers providing the same level of multidisciplinary care, but with the adult medicine in mind. Many of you do know that 50% of our seniors with Down syndrome after the age of 40 do start to develop signs of dementia. We want to make sure we are there to help them, support them, and diagnose accurately, and make sure that they get the support that they need in this clinic. Next click. We believe in our clinic that it's much more than just a medical visit. It really is a whole wellness visit, and this is why all of our patients are seen by these multidisciplinary team members. I'm also proud to say when I see a patient, I don't even see a patient alone. I see my patients side by side with one of our social workers in our program, because we believe that mental wellness and medical wellness go together and there's great interplay. We also question the premise, oh, that's just a part of Down syndrome. Oh, that's the way those kids get. Oh, that's the way adults are. We reject that premise until we're able to make sure that all the co-occurring medical conditions are treated and taken care of. We reject that premise until we make sure some of the mental co-occurring conditions like depression, anxiety, OCD, ADHD that could co-occur with Down syndrome are not only diagnosed, but also treated. We also believe the importance of Down syndrome healthcare maintenance. We like to play offense rather than defense. We know that at certain ages, certain medical conditions could start to pop up. We want to be there to be able to anticipate those and be able to pick up the early signs so that we don't reach any medical or mental health crises. We also know that mental health challenges vary based on age. If we go back one slide. And we also know that sometimes the only clue that we're getting from people with Down syndrome about changes in their medical care or mental wellness is changes in their behavior. So we're relying not only on our patients, but also on their caregivers and their family members to help us understand what is different and what is changing so we could help get to the bottom of things. Next slide. I thought I'd share with you a couple of cases as though we're in clinic together. These are real cases. And this is an 8-year-old with Down syndrome who came to us about a year ago to establish care. The parents were very worried about the patient's behaviors. You see, at school and home, this is a patient who started to bolt, which means run away, start to hit others, and drop and flop with task refusal. The teachers were trying everything they could with behavior management. Parents were trying, but these behaviors started to get in the way. When the patient came to see us, we realized this patient was not up to date on thyroid screening, was having infrequent bowel movements and also had a recent sleep study that showed severe obstructive sleep apnea. So this is a family that was working with the school, and the family and the school started to get frustrated with all the behavioral plans that they had in place. And this is someone who came to us and said, our school feels that our son or daughter needs some mental health medication, or psychopharmacology as we call it, in order to help with the behaviors. But by doing a full roundabout approach, we were able to realize that this severe obstructive sleep apnea, which we helped diagnose with the sleep study, was really causing some of the brain fog and the behavioral dysregulation, because without getting a good oxygenated sleep, people with Down syndrome could easily have behavior disruptions. We then were able to send this 8-year-old to our colleagues in ears, nose, and throat, who were able to do an examination and realize that the tonsils and the adenoids were huge and getting in the way. We were able to work with the family to get those tonsils and adenoids removed. We repeated the sleep study, which showed the apnea was cured. And within a month or so, this is a patient who started to get good, consistent oxygenated sleep. And what happens when you're well rested? You're better able to regulate yourself. And this was someone who was able to regulate their behaviors, and all of these problematic behaviors started to slowly abate. This is someone who, in this case, did not need psychopharmacology, but in this case needed the medical component. So this is a way of us looking at all aspects of a patient and being able to tease out what might be this answer. Next slide. When we have someone come to us with behavior issues like this 8-year-old did, we have this whole screening. So on the left-hand side, I typically take care of the medical workup. We think about some medical conditions that might present with some behavioral dysregulation. I also think about expressive language skills. If someone with Down syndrome is not able to be understood, that could be frustrating. And then I work with my colleague Chloe and my social work colleagues and those in psychology and psychiatry to also do a mental wellness screen. Perhaps in this case, it's not going to be anything medical related, and it is a child who perhaps is just struggling with a new change in their environment, a new change in school with COVID. So much regression is happening with COVID as we're all forced in these surreal Zoom environments to interact. But maybe it's also a real mental health condition like ADHD or OCD, which does need to be diagnosed accurately, and people with Down syndrome can and do deserve the same treatments that people in the typical developing population get for their mental wellness. Next slide. I want to share with you another case study. This was a 28-year-old who I had never seen in our Down syndrome program, but we got a call from our inpatient services. Many of you know MGH has lots of different inpatient services, but this was a call from oncology, or the cancer unit. They just had admitted through the emergency room a 28-year-old male with Down syndrome who had a new diagnosis of leukemia. And although rare in the adult population, it's not impossible. And they reached out to us to say, you know, our oncology team is used to treating children with Down syndrome, but we're not used to taking care of adults. Can you help us? This is a particular consult where they're not looking to us for the oncology treatment. My colleagues who are trained in cancer, they know how to take care of the leukemia. But we're so grateful we've developed this relationship, because we've developed some skills and some resources and some toolkits in order for our colleagues to be able to better identify the wants and needs, and to allow the people with Down syndrome who are hospitalized to have their voices heard. On the next slide, I'm going to show you what one of those looks like. Many of our patients with Down syndrome use picture communication systems, or what we term augmentative and alternative communication systems, to communicate. This is a patient who had some challenges in some expressive language. And we wanted to make sure that even when the parents were not there at his bedside, we would be able to capture and allow this person to express their wants and needs to the nursing staff and to the clinical team. So this is a picture communication board where you could see there are pictures that say suction mouth, or pain in throat, or I'm thirsty. So if the person with Down syndrome who might not be able to express themselves or be understood fully, by pointing to the right symbol, they would be able to communicate. And we found by providing and customizing this chart for our colleagues, they were able to start to engage and better understand the patient with Down syndrome, and of course allow him to be involved in his medical care. Next click. We also, for those patients who are hospitalized, have an I hurt board. So if something is hurting, sometimes people with Down syndrome have trouble identifying it, or when they're hurting, have trouble finding the word to use. So in this I hurt, you see they could go around and we say, where does it hurt? Oh, it hurts in your back. okay, well, maybe it's time to roll the person over or to position a pillow underneath them. Maybe they're hurting in their neck. What could be going on in their neck? Again, we know that caregivers know their loved ones well with Down syndrome, but sometimes they can't always be at the bedside. And still, even then, we want the person with Down syndrome to be able to help contribute to their medical care and allow their voices to be heard. We also like first then statements. Sometimes we need to break things down into simple steps so that people with an intellectual disability can understand. And in this case, there were a lot of procedures that were going on. And so we might say, first, we need to draw this blood, then it will be time for you to have your lunch. So the person with Down syndrome understands that there's two steps. Oh, I see that my lunch was just delivered to my inpatient room. I want that lunch. Oh, but first I need to get this blood work done because it's important. So oftentimes we like to help train our colleagues in the inpatient to break things down into simple first then statements, which seems to be helpful. So this is just a small way of saying, in this case, we received a consult about a 28-year-old with Down syndrome, and rather than being tapped for any sort of medical expertise, we were proud to be able to bring what we've learned from our patients, from our families, to bring communication, to bring voice, and to more importantly, to make sure that the person with Down syndrome has the dignity to respond to their medical care. Next slide. I want to talk about access to care. You know, we are so fortunate, and I'm so proud to be able, with my colleagues, to offer care to the 600 patients with Down syndrome who make it to our MGH Down Syndrome Program. We do see people from all over our state of Massachusetts, but they also come from lots of other states and lots of other countries. There are 71 of these Down syndrome specialty clinics in the United States, but as you can see from the last bullet, all of our clinics combined at maximum could only see 5% of our population of people with Down syndrome. It means 95% of people with Down syndrome don't have access to one of these clinics. And we're not going to be able to continue to expand our clinic. Plus, it's not socioeconomically reasonable for everyone to pick up and travel to one of these clinics. We also know that primary care doctors maybe only have 1 or 2 patients with Down syndrome in their particular primary care practice. So it really is impractical and unreasonable to think that primary care doctors can remain up to date on everything related to Down syndrome. So as such, I'm very proud to share with you on the next slide something that we're developing to bring our expertise to people around the globe. We have just launched Down Syndrome Clinic to You, or DSC to You. And if you're listening right now and you have your phone or your iPad and you want to check out this website right now, I'm not offended. You could turn away and you could check out this website while I continue to talk, because I am so proud of this. We are bringing healthcare to families so that families don't need to come to healthcare. This is an entirely automated direct-to-consumer tool that's available in English and in Spanish. And on the next click, I'm going to show you how this works. So wherever you are in the world right now, you could go to our website. You don't need to be a patient of Massachusetts General Hospital. And with the fee that we ask you to charge for DSCDU, you will get access to an intake form. When you get that intake form, you will be asked questions that are specific to Down syndrome about your loved one with Down syndrome. Now, we've also learned from family members that they don't like completing long intake forms. So we have branching logic here, where how you respond to some questions determines what questions we ask in subsequent sections. So we will know in subsequent questions whether to ask you the 35-year-old female questions or the 5-year-old male questions. On the next click, you will see that we have 10 different sections on the left of our Down Syndrome Clinic to You. The more families complete, the more they're going to get in return. Section 2 is the current medical concerns. These are all the combinations of symptoms that might add up to a co-occurring condition for and with Down syndrome. Now, I want to mention that there are no responses here that are fill in the blank. There's no type your responses. And that's because this is automated. In order to make us scalable, we needed to have something that's automated. And let me share with you a little secret. After all these years of seeing hundreds of patients with Down syndrome, I've really become a super trained pattern recognizer. So if someone says I have an 8-year-old with Down syndrome who's snoring at night and tired during the day, I know that the pattern of those symptoms add up to obstructive sleep apnea. And out of my mouth is, let's go get a sleep study done. Well, why do you need to make an expensive trip all the way to Boston to see me in my clinic for me to tell you that? So my team spent over 2 years downloading our brains. Every decision that we make in person, we thought about what are the questions we ask our patients and our families, and let's program them in. Not only did we ask our physicians to do that, we asked our social workers, our nutritionists, physical therapists, occupational therapists, speech therapists, all the people in our program to download the questions so we could capture them here. On the next click, you will see that section 3 is all about the mental health and mental wellness. These are the behavior symptoms that might exist in people with Down syndrome that in combination might start to add up to ADHD, obsessive compulsive disorder, or perhaps depression or anxiety. This is also a screenshot to show that the entire intake form and also the output is available in Spanish. We are very grateful to our grantor, which was the Patient-Centered Outcome Research Institute, or PCORI, for giving us this $2 million grant to create this tool and allowed us to be able to translate everything into Spanish to make it more fully accessible to families around the globe. Next click. You could see here in section number 7, it's our nutrition and swallowing section. So these would be the question that our nutritionist would ordinarily ask if you were to come to see us in person. But now we're asking those questions here. Again, this section is optional. So if a family doesn't want to complete it, they don't have to complete it. But if they do complete it, in a couple of slides, I'm going to show you what they get. And on the left-hand side, you see that there are so many other different chapters there, one on schools, therapy, and resources. And just as much as our in-person clinic is not just a medical clinic, our online virtual clinic is more than just a medical diagnostic clinic. We're going to ask questions about, do you have any questions about how best to teach reading to people with Down syndrome? How best to teach math to people with Down syndrome? If your loved one with Down syndrome wants to get a job, what are some vocational helpful resources that are available? How do we make sure that people with Down syndrome have the skills they need to be as semi-independent as possible when they become adults? We have that programmed here too. We also know that families have questions about psychosocial services. When do I sign up for SSI? What is SSI? If I want to get guardianship, what do I need to consider? How do I go about getting legal guardianship? What are the financial instruments that are out there to save money for my loved one with Down syndrome without sacrificing their eligibility in some of the social services? All that we've learned from our patients, we are proud to program in here and give back to families like my own who cannot make it to Boston. Next click. You can see here, we're also going to ask Kristen, our sample patient here's parents about things that have been done in the past couple of years. Has she had a hearing test? Has she had an eye appointment? Has she had that sleep study? Because again, those answers are going to help us formulate through our algorithms what recommendations we're going to provide to Kristen's mom. Next click. After a caregiver completes that intake form, which could take anywhere from 10 to 40 minutes, depending upon how much they want to get into it, how thorough they want to be. When they press submit, they get taken to their own personal portal. And this really is the magic of Down Syndrome Clinic to You. In this personal portal, which is password protected that only the caregiver could access, in the first tab is going to be all the recommendations customized and personalized for that family. In the second tab is going to be the same set of recommendations, but this time written in language for the primary care physician, so that now they could take these recommendations to their primary care doctor to be able to turn their primary care doctor into a Down syndrome specialist. In the upper right-hand corner, you see that thing that says language. With a simple click there, you will be able to turn everything into Spanish. And also in the upper right-hand corner, download, if someone were to click that, they could download all the information in their portal into a PDF that they could either print out and or email as an attachment to their clinicians that they want to share with. Now, if we were online live, you would be able to see that this is a scrolling checklist, but for the sake of this presentation, I have chopped it into screenshots, and on the next click, I'm going to show you what the caregiver checklist looks like. The first section is about labs, tests, and procedures that Molly needs to get. So the way that Molly, our sample patient here, and her mom responded to our intake form, you could see she's due to get an eye exam, due to get a celiac screen, due to get a sleep study, due to get thyroid tests. Now, we created this hand in hand with caregivers, hand in hand with primary care doctors. And I have to say, it was such a joy being able for 2.5 years to work with all of these caregivers and these primary care physicians to provide input, because I would write copy and they would look at it and they say, Dr. Scacco, no one could understand what you have to say. You have to break it down, right? So this really was a collaborative effort to get it right. And what we learned is that there are some caregivers, some family members who have so much on their plate, they say, we trust you, just tell us what to do and we'll get it done. There are other caregivers who say, if you're going to recommend something for my loved one with Down syndrome, I want to know exactly why you're recommending it. And so for those people who fall into the latter category, after each recommendation, you see there's a green Y button. And if a caregiver were to click on one of those Y buttons, they would get an explanation why. So let's zero into thyroid function test there. And let's pretend we click on the Y button. With the next click, you will see that you have a dropout box. And this dropout box was informing the caregiver, well, you see in the past 12 months, you've indicated that Molly has not had her thyroid levels drawn. And people with Down syndrome have a significant chance of developing thyroid problems, which is important to treat. We recommend getting thyroid treated at least once a year. So we're telling the family why we're making those recommendations if they want. Then our team also spent about 1.5 years going through the internet and curating accurate, credible medical information so that when we make these recommendations, we could also deliver credible links so that families could learn more if they want to learn more. So you see here we have 2 links. One's a video and one's information. So on the next click, if the family were to click on a video, it would take them to our colleagues at Boston Children's Hospital who have a great free video on thyroid dysfunction and Down syndrome. And on the next click, it would take them to the National Down Syndrome Society's webpage, which has great information about endocrine conditions and Down syndrome. Now, these things exist. They're on the internet right now, and they're for free, but no one knows to go to look for them. So we are going to bring them to families when the symptoms seem to be right in a personalized manner. Next click. We next have a section on the caregiver checklist about newer known conditions that might be considered for Molly. Now, it's important to say at all times, we have and do and want to respect the patient-doctor relationship. This should be a conversation starter between Molly, her caregivers, and her primary care doctor. They need to read this carefully and decide, does this really apply to Molly or not? But based on the symptoms that Molly's mom put in, we see that Molly might also have a co-occurring condition of depression. Sometimes people say, oh, that's just the way adults with Down syndrome get. Well, let me tell you something. I had a patient with Down syndrome who came to me, who slowly became more nonverbal, who slowly became downcast. And this is what the mother was told. This is the way these kids get. But we were able to do a medical workup and work with our colleagues in psychology and psychiatry to help make the diagnosis of depression. And on just the smallest dose of antidepressant medication, this person came back and could be who they are. This is about restoring people to who they are, and sometimes they can and do deserve the same treatments that the neurotypically developing population gets. But you have to be careful in terms of distinguishing what is Down syndrome and something else. We're fortunate enough to be able to have that expertise through the hundreds of patients that we've seen, and now we want to share that knowledge with Molly, her caregiver, and her primary care provider. You can see here we give the explanations why, and with a click, you will see, read chapter 14 of this book. We are directing Molly's mom to the exact chapter in this book we recommend that she reads. She could buy that online or get it from her library. I have heard loud and clear from caregivers, they don't have time to read whole books anymore. So we are trying to direct them whenever possible to the exact chapter, or next click. You can see under bone and joint conditions, if we go back one slide, please. Under bone and joint conditions, you see on page 181 to 185, we've tried to be as specific as to direct them to what pages they should be able to go to. Then at the bottom of this screen, you see that health and wellness information for Molly. This is where we go beyond just the raw medical recommendations. Molly, based on her and her mother's responses, have questions about oral contraceptive pills, about dating and social boundaries, sexual development, about weight management. We're there for her and her mom, and we're here to deliver our recommendations and also the medical information. Next click. Molly's mom completed the nutrition section, so we're able to give her nutritional recommendations here. And on next click. When individuals with Down syndrome are 12 and older, we're also asking them and their caregivers to complete a life skills checklist. We've learned from people with Down syndrome and their families that they want to be able to help them be as semi-independent as possible. And sometimes those steps towards independence can be broken down, and sometimes we can help them achieve some of those. So you can see here that Molly's mom wants her to learn how to describe how she's feeling to her doctor on her own, what her medications are for, what's the difference between healthy and unhealthy foods. For each one of these recommendations, we have a resource that Molly and her mom could use. So if we were to just kind of zoom our eyes and halfway down to Molly's wants to learn how to use public transportation on her own, we see that there is a blue link for a resource. And on the next click, you will see that that takes Molly and her mom to what we consider a social story. This is kind of a picture workbook, if you will, that we've created through our program to help people with intellectual disabilities learn how to use public transportation on their own. We've worked with families to create this. It's free, it's on our website, but again, no one knows to look there. So we're going to try to deliver it when the need arises and when people access it. And again, they don't need to be patients at MGH in order to get this quality information. Next click. We also have a section on education and therapies. Molly wants to be able to get a job. So you can see here, we're offering links on how she could enhance her employment opportunities and what resources are available for her. It's here we'll be able to answer in this section if they have questions about teaching math, teaching reading, teaching in general, education in general, adaptive living skills. And then at the bottom, we have all of the social services that can be available to some people with Down syndrome at different ages. Here, Molly's mom has a question about Social Security insurance, how she applies. Molly's mom has a question about ABLE accounts and special needs trusts. Again, no need to make a trip to see us. We're able to bring our resources and guide you through that with links that will that we would ordinarily be handing out in person. Next click. And next click, please. This is just a screenshot. If we go back one click. This is just a screenshot to show that everything is also translated into Spanish. So while the input can be translated, so can the output. Let's go to the next slide. Now we're back at the patient portal. Again, this is for Molly and her mom and her caregivers. And if they click on number 2, which is the primary care provider plan, this is the letter for primary care physicians so that Molly's mom could either print this out, download it, or email it to their primary care doctor. On the next click, you will see it's all the same recommendations that we gave Molly and her caregivers, but now it's written in doctor talk. Because we heard from our primary care consultants that they need things written exactly what we should order, why we should order it. So you can see the second recommendation here, celiac screen. We're not only sharing what are the symptoms that raise our suspicions, but we're reminding the primary care doctor what labs to draw, in this case, the total IgA and the TTG IgA. The bottom, you could see, here are the other co-occurring conditions that Molly might have that we really want the primary care doctor to have an open and honest discussion about with Molly and her family. And here are some of our reasons and the symptoms that we got through the intake that suggest that these might be a consideration. Next slide. I am proud to say that we have published the results of the research that we did on this. Before we launched this, we wanted to test it to make sure that it was usable. And so we had, over the past 2 years, 230 families from around the United States test out Down Syndrome Clinic to You. Half of those families got Down Syndrome Clinic to You. The other half did not. They were simply seeing their primary care doctors as they typically see. What we were able to determine is at the end of the study, Down Syndrome Clinic to You was both effective and satisfactory. And I'm going to share with you some of those results, but this is the research paper that just came out last month. Next click. We were able to determine that Down Syndrome Clinic to You is effective. Those in our research study who got Down Syndrome Clinic to You had a 1.6-fold increase in the number of healthcare items that should have been done that they actually got done or were recommended by their primary care doctor. Put another way, these hints, these reminders, these checklists are able to bring Down syndrome specialty care into the primary care setting. Next click. But I also wanted to make sure with my team that not only was it effective, but it was something that was meaningful, useful, something that could be really used by caregivers and primary care doctors. So we asked caregivers throughout the study, was this easy for you to understand? And you could see that nearly 97% of parents that it was easy for them to understand. Would you recommend this? And you could see they would all recommend Down Syndrome Clinic to You. And did you use all those links that we embedded? 75% of patients and their families used it, and the other 25% just took our recommendations, which is fine. Next click. We also wanted to make sure that primary care physicians also liked Down Syndrome Clinic to You, because we wanted to make sure it wasn't just, oh, another burden or an onus. Here goes Harvard Medical School again, trying to tell us what to do. That's not what we wanted to achieve. Instead, we wanted to make it simple and easy and be a guidepost for them, because we recognize, again, they want to do the right thing, but might not have the expertise that we have by seeing the hundreds of patients with Down syndrome. We were very relieved and happy to see that our primary care physicians who participated in our study were really satisfied with Down Syndrome Clinic to You. You can see they all discussed the primary care plan with their patients and their caregivers. They agreed with the recommendations, and they were really interested in the information that we offered. And I want to really thank the primary care providers who were co-researchers with us and helped create this, because they allowed us to be able to get this right and get the verbiage right so that it would resonate well with today's hardworking primary care physician. Next click. We asked everyone on a scale of 0 to 10, 0 being awful, 10 being amazing, 5 being middle of the road, how would you rate Down Syndrome Clinic to you? And you could see our first version was a 7.8 from both the PCPs, the primary care doctors, and the caregivers, and we were so happy to see that rate. We also got great feedback, and we're continuing to get great feedback. And Down Syndrome Clinic to you continues to be a work in progress because it needs to be a work in progress. We want to continue to tweak it and update it to make sure it's helpful to families. Next click. I'm so proud to let you know that Down Syndrome Clinic to you is no longer just a research entity. It has been launched, it is available. And I want to thank the Lumine IDSC Down Syndrome Foundation, who gave a 3-year philanthropic donation to our program, which allowed us to convert and make sure all the machinery is in place to launch Down Syndrome Clinic to you. Next click. What does this mean? If you are a family tuning in who has a loved one with Down syndrome, no matter where you are around this globe, if you have access to the internet and can access things in English and in Spanish, Down Syndrome Clinic to you is ready for you. Right now, it's $49 per usage, and that helps us maintain the costs of Down Syndrome Clinic to you, which includes the cost of maintaining the servers, maintaining the security of the data that comes in, and also making sure that we update the algorithms. We want you to know that when you tune into Down Syndrome Clinic to you, it is being updated with the most accurate information. As new research comes out, as my team is reviewing it, and we say, oh, this is a change in the way we practice medicine for people with Down syndrome. Not only do we update how we practice medicine on the ground in our clinic at MGH, we're updating our algorithms so that no matter where you are around the globe, you're getting those same recommendations. What our hope is for Down Syndrome Clinic to you to be financially sustainable. The user fees that come in will be able to maintain the maintenance of Down Syndrome Clinic to you so that the community can have it forevermore. Next click. My team and I also recognize that $49 right now might be a cost that is prohibitive for some families right now around the globe. So we are working with Down syndrome nonprofit organizations who want to give the gift of health to their members. For example, there is a Down syndrome organization in another state where there is not a single Down syndrome clinic. And they said, you know, we have these walks, we have these fundraisers, Dr. Scacco, and our members cannot get on a plane and fly to Boston. And so what they did is they purchased 100% coupons to Down Syndrome Clinic to you, and they purchased on behalf of their members, and they're giving those coupons and their discounts out to those members. So we've set up a special relationship for organizations who again want to purchase those codes so that they can either bring a partial or a full discount to their members. Next click. I am really dedicated, however, to making sure that Down Syndrome Clinic to you soon is covered by insurances. I've started to have conversations with healthcare insurers, and this is a win-win for everyone. We are able, through a simple online mechanism, to be able to bring high-cost specialty care into low-cost primary care settings. That is, we could keep people with Down syndrome healthier at a lower cost. And that makes families happier. They don't need to travel. They don't need to come into town. They don't need to find one of these limited in-person clinics. It makes primary care doctors happy because we tell them exactly what needs to be done without being a burden. And it makes insurers happy because they don't need to be charged the expensive fees from perhaps a specialty clinic like mine, and rather this can be done in the context of primary care. So please check back this website at dsc2u.org/insurers. We are currently working with insurance companies, and we will soon be able to post those which will make Down Syndrome Clinic to you available for free. That is, people will enter their insurance information, they will be charged $0, and we will be able to get reimbursement from the insurances so that families don't have to pay. I have to say, this is a new adventure for me. You all know I'm a physician. I am trained in medical genetics, but I'm having to learn the business of being able to get health and wellness information out there. I am more than happy to speak to anyone in an insurance company, but if you have a loved one or if you have a connection to someone who is in an insurance company, I'd be grateful if you reached out to me because I would love to talk to them as we work together with insurances to, again, bring Down Syndrome Clinic to you, to families. Next click. All of you who are listening, I hope at minimum you'll help us spread the word about Down Syndrome Clinic to you. No longer does geography, hopefully no longer does cost need to be inhibitory for people with Down syndrome and their family from getting quality of care. Again, we're so grateful and proud to provide the care we do in person, but now our dedication is to make sure that same quality of care we provide reaches anyone with Down syndrome around the globe. And you can find our postings on Facebook and on Twitter here. Next click. We also think that Down Syndrome Clinic U can serve as a blueprint for other specialty clinics within MGH. For example, MGH has an excellent Marfan syndrome clinic. They have an excellent adult congenital heart disease clinic. They have an excellent Alzheimer's clinic. We hope that Down Syndrome Clinic to You and the machinery of it could soon turn into the Turner Syndrome Clinic to You, the Marfan Syndrome Clinic to You. And we are working with our colleagues here to be able to extend MGH's level of care to people from around the world. And we're going to be working on that because the technology for this was all created within the laboratory of computer science here at MGH. Some people didn't realize, I didn't before I came to MGH, that MGH has a whole team of computer software engineers who are continuing to create and invent new ways of using technology to decrease the barriers and increase the access to medical care. Next slide. One thing we need to do though is we need to make sure that Down Syndrome Clinic to You is easily able to be transformed for other conditions. Those of you who use Microsoft Word, you know when you click on the B button, it just magically makes something bold because that's what the B button does. But when we click on the B button, behind the scenes, it starts to turn everything into code, right? Down Syndrome Clinic to You is just raw code. We have no B buttons, we have no enter buttons. And so in order for us to be easily able to adapt Down Syndrome Clinic to You into other conditions, we're looking for a transformational gift, a one-time gift, which would allow us to do that. And we're working really hard to be able to find that gift. So again, Down Syndrome Clinic to You can expand to other conditions. Next click. Lastly, I just want to thank all of you. It's not lost on me that you have dedicated an hour of your day to learn more about Down syndrome. I want to thank the Blum Center for recognizing the importance of Down syndrome. And I want to thank all my colleagues who work within the MGH Down Syndrome Program and throughout the hospital for continuing to take good care of our loved ones with Down syndrome. Thank you so much, and I look forward to taking your questions.
All right, thank you so much, Brian, for the informative presentation. So we will now transition into the Q&A portion of the presentation, and we do have a few questions here. So one person asked, do you plan on adding more languages to DSCTU in the future?
So the question is yes. There is both a linguistic translation and a cultural translation. So for those who speak a language who just simply need to translate it, we're working to find the philanthropic donations to be able to translate it. But sometimes the linguistic translation is not enough. My wife and I had a recent opportunity to travel to Saudi Arabia to work with the Down syndrome community there. And we know that there is a different way of practicing medicine. And we also know that there are different social and educational norms there. So sometimes it's not just linguistically translating, but you have to get into the code and write different algorithms. So that is what we call a cultural adaptation of Down Syndrome Clinic to You. Both are possible, but both require increased donations to make that happen. And we are actively working with groups who want to raise that money to allow us to be able to do those adaptations. Our mission is, our work is not done until no matter where you live on this globe, you can access Down Syndrome Clinic to You in a language and a culture that is specific to you.
All right, thank you so much. Someone else said, this is an amazing tool for families. I'm curious if the tool makes any recommendations for families around accessing community resources. For example, encouraging accessing early intervention services, which their child would already be eligible for based on the Down syndrome diagnoses.
Thank you for that question. And for those of you who might be new to early intervention, this is a federally funded and state supplemented service for physical therapy, occupational therapy, and speech therapy, among others, for those with certain disabilities, Down syndrome included, under the age of 3. People with Down syndrome absolutely benefit from early intervention services. And yes, in this intake form and in our output, if it looks like people need more physical therapy, occupational therapy, or speech therapy, we do provide those information. And we also provide links to some of the best materials out there on how best to teach gross motor, fine motor, and speech and language skills to people with Down syndrome.
Okay. Another question here is, obstructive sleep apnea is a very significant risk in our loved ones who have Down syndrome. Research is telling us it is present in 50 to 100% of all adults who have Down syndrome. Is it possible that better detection and treatment of this condition will decrease the rate and severity of dementia in older patients with Down syndrome?
It's such a great question, and it is true. Obstructive sleep apnea is so common in people with Down syndrome, and the challenge is a lot of obstructive sleep apnea is silent, meaning it gives us no clues whatsoever. So if someone with Down syndrome is snoring at night, choking at night, gasping during the day, falling asleep during the day, of course, those are signs of obstructive sleep apnea, and we need to look out for them and make sure they get a workup. But sometimes it could be subtle. It could be a change in behavior, it could be a change in baseline, it could be a change in cognition. And that could be the silent apnea. So it is important to detect that. And Down Syndrome Clinic to You is really programmed to look at all those variables and recommend it. This, the question also alludes to the fact that when people with Down syndrome get older, I mentioned that about 50% of them at the age of 50 will develop dementia related to Alzheimer's. But that doesn't mean all symptoms are Alzheimer's. It's important to disentangle if there is confusion or behavioral issues. Are there other co-occurring conditions that are not Alzheimer's? And one of the biggest things where people could start to become confused, have brain fog, or perhaps lose cognition is the impact of obstructive sleep apnea. So if we're detecting any signs of behavioral change or memory loss in adult, we can and do recommend a sleep study workup to make sure it's not obstructive sleep apnea. If it is obstructive sleep apnea, there are lots of treatments and lots of supports, and we do offer those through our new instrument, Down Syndrome Clinic to You.
All right. Someone else asks, are there current openings at the MGH Down Syndrome Clinic? How can clients access these services?
Yes, there are. We are happy to see anyone from around the globe who would like to come to our in-person clinic. I just recommend you check with your insurance to make sure that your insurance will cover the visit. But if you're interested and you go to our webpage, massgeneral.org/Down syndrome, you will see a button that says request an appointment, and there will be an intake form. Complete the intake form, and that will go to our program. This is separate from the Down Syndrome Clinic to You. So our in-person program has an intake form. Once we receive your intake form, then our schedulers will reach out to you in order to book that appointment. Right now, during the COVID-19 pandemic, all of our clinics are now virtual, and we're doing remote multidisciplinary clinics, which have been working very well and making our clinic even more accessible to those who can't come in person.
All right. Since we're nearing the end of the presentation, I'll just take this last question. You mentioned co-occurring mental health conditions showing up in 13 to 12-year group. Could you elaborate?
Sure, and it's not just specific to the 13 and 21 group. We know that there are some co-occurring mental health conditions in the younger group and in the older group. Some of those could be Down syndrome and autism, Down syndrome and attention deficit hyperactivity disorder, known as ADHD, Down syndrome and obsessive compulsive disorder, known as OCD, Down syndrome and depression, Down syndrome and anxiety. These are some of the many kind of co-occurring mental health conditions that, if they are not caused by any medical issues and are true diagnoses, we want to make sure that the person gets the help that they deserve and also the treatments that they deserve.
All right. Thank you so much again, Brian, for the presentation. And thank you so much for the audience for tuning in and participating. So we are going to wrap up this session, and I hope you all have a really nice day. Thank you.
Thank you for having me.